Hello students, welcome to today's session on papillary thyroid carcinoma. This is the thyroid cancer you will see most commonly in exams and in clinics. In this session we will break down step by step so that by the end you will be confident spotting it in questions, slides and patients. Today we are diving into papillary thyroid carcinoma, the most common thyroid cancer. Don't worry, it sounds scary, but it's actually one of the most well-behaved malignancies. By the end of this session, you will know its key features, risk factors, how it looks under the microscope, and of course, how to crack exam MCQs on this topic. So let's get started. So papillary thyroid carcinoma or PTC is the most common thyroid cancer, making up almost 80% of cases. It comes from thyroid follicular cells and its superpower is having distinct nuclear features that pathologists love to ask about. The best part, even though it's a cancer, the prognosis is usually excellent. PTC is seen most commonly in women, usually between 20 to 50 years old, and a big risk factor, radiation exposure, especially in childhood. In fact, many cases are picked up incidentally, like when a patient has a thyroid ultrasound for some other reason. So it's more common than you think. Now, the main culprit is radiation exposure, but genetics also play a big role. Add to that family history and iodine intake, and you have got a perfect recipe. So, if you see a case history with radiation exposure in childhood, PTC should be your top guess. When you look at PTC grossly, you will see a firm white tan nodule in the thyroid. Sometimes it's single, sometimes it is multiple. Calcifications may also be visible, but honestly, the real picture begins when we zoom into the microscope. Okay, this is the most high yield slide, the histology of papillary thyroid carcinoma. If you remember one thing from today, let it be these features. First, the papillary architecture. You will see branching papillae with a fibrovascular core. This is why it is called papillary. Next are the famous nuclear changes. First is Orphan NEI nuclei. So the nuclei look empty and clear, just like cartoon eyes from Orphan Annie. This is the classic buzzword. Nuclear grooves, longitudinal lines across the nucleus, like coffee beans. Intranuclear cytoplasmic inclusions. Sometimes the cytoplasm actually pushes into the nucleus, so you see these inclusions. Another feature are Psammoma bodies. These are tiny, round, concentric calcifications. The name comes from Greek Samos, meaning sand, because they look like little sand grains under the scope. Finally, the nuclei are often crowded and overlapping, giving that ground glass look. So whenever you see Orphan Annie nuclei, nuclear grooves, Psammoma bodies, the answer in your exam is almost always papillary thyroid carcinoma. So these are the cytology findings, and in this picture you can see this is the entire follicular cell. Inside that there is a big circle like structure. This is the nucleus, and inside this you can see rounded structures. These are intranuclear cytoplasmic inclusions. Here also you can see this blue colored big circles are the nuclei. Inside that you can see the clear structures. These are intranuclear cytoplasmic inclusions. Now let's talk about the variants of PTC. These are important because they can look different under the microscope and some behave more aggressively than others. Okay, let's make this really simple with a quick comparison table. Classic PTC is the standard one with papillary fronts, classic nuclei and Psammoma bodies, and it has the best prognosis. Follicular variant can be confusing because it looks like follicular carcinoma, but the trick is the nuclei will still show papillary features, so always check the nuclei. Tall cell variant, think of tall thin cells at least twice tall as wide. Sadly, this one is more aggressive, often seen in older patients. Next is diffuse sclerosing variant. Instead of being a single nodule, it involves the whole gland. You will see the dense fibrosis, lots of lymphocytes and Psammoma bodies everywhere. Prognosis is worse here too. And finally, the rare columnar or hobnail variants. These are less common but important for exams and they usually behave badly. So when you hear variant of PTC, don't just assume it's all the same. Prognosis depends on which variant you are dealing with. Now this is the slide which shows microscopic diagrams of PTC variants. First picture shows follicular variant. You can see follicles lined by cells showing clear nuclei. Second picture also is follicular variant. You can see follicles lined by clear looking nuclei. Third picture is tall cell variant. In this you can see tall thin cells and nuclear features are same, that is you can see clear nuclei. This diagram shows diffuse sclerosing variant. This pink colored homogeneous structure you can see, this is the sclerosis. These are Psammoma bodies and you can also see clear nuclei in between. Last diagram is hobnail variant. You can see cells looking like hobnails. Hobnail, you can see this diagram. So cells are looking like hobnails and nuclear features are showing nuclear clearing. Clinically, most patients come with painless thyroid nodule. Since PTC spreads through lymphatics, cervical lymph node enlargement is also common. If it grows big, it can cause hoarseness or difficulty swallowing. Distant spread to lungs or bones is possible, but not as common as lymph node. Ultrasound gives you clues like microcalcifications and irregular margins. But the gold standard is fine needle aspiration cytology. It's quick, safe and super accurate. Molecular testing for BRAF or RET mutations can also help. And finally, histopathology confirms the diagnosis after surgery. So students, now the good news. PTC has an excellent prognosis. More than 95% survival at 10 years. But prognosis is best if the patient is young, tumor is small, and there is no spread beyond the thyroid. On the flip side, older age, larger tumors, or aggressive variants make the outlook worse. Okay, management starts with surgery, either a lobectomy or total thyroidectomy, depending on tumor size and spread. Some patients get radioactive iodine to destroy leftover thyroid tissue. Then we put them on thyroid hormone therapy to suppress TSH and reduce recurrence risk. Long-term follow-up includes checking thyroglobulin levels because if it rises, it hints at recurrence. So students, to wrap it up, PTC is the most common thyroid carcinoma linked to radiation exposure with those classic nuclear features, orphan nuclei, grooves, Psammoma bodies. It usually spreads to lymph nodes, but the prognosis is excellent with the right treatment. Definitely a favorite for examiners. So students, now we will begin with 3 MCQs which will cover the hallmark histology, variants and the spread pattern, all favorite exam questions. Remember, orphan nuclei and Psammoma bodies scream papillary. Tall cell means trouble, aggressive, worse prognosis. PTC loves lymph nodes, while follicular carcinoma loves blood vessels. So first question consists of a 35-year-old woman presents with a painless thyroid nodule. FNAC shows orphan nuclei and Psammoma bodies. What is the most likely diagnosis? Your options are follicular carcinoma, papillary carcinoma, medullary carcinoma or anaplastic carcinoma. So the answer is B, papillary carcinoma, because orphan nuclei which are also known as optically clear nuclei, and Psammoma bodies, that is concentric calcifications, are classic diagnostic features of papillary thyroid carcinoma. Follicular carcinoma shows capsular vascular invasion, not nuclear features. Medullary carcinoma arises from C cells and shows amyloid stroma. Anaplastic carcinoma is highly aggressive with pleomorphic giant cells. Now, second question, which variant of papillary thyroid carcinoma is associated with more aggressive behavior and worse prognosis? So, the options are classic variant, follicular variant, tall cell variant, or papillary microcarcinoma. So, the answer is C, tall cell variant. Remember students, in tall cell variant, cells are twice as tall as wide, associated with older patients, and shows aggressive clinical course with higher recurrence and mortality. Classic variant has excellent prognosis. Follicular variant is indolent, similar to classic. Papillary microcarcinoma, which is less than 1 centimeter, has excellent prognosis. Now the last question. Papillary thyroid carcinoma most commonly spreads via which route? Hematogenous spread to lungs and bones, direct extension into trachea, lymphatic spread into cervical lymph nodes, or perineural spread? So the answer is C, lymphatic spread to cervical lymph nodes, because it characteristically spreads via lymphatics to regional cervical lymph nodes. Follicular carcinoma, in contrast, spreads hematogenously to lungs, bone, and liver. Direct extension and perineural spread are not typical features of PTC. So students, thank you for watching today's episode on papillary thyroid carcinoma. Don't forget to like, share and subscribe to Medibits with Dr. Shraddha. If you have any questions or topic you would like to be covered, drop them in the comments. In the next video, we will be tackling in a similar high yield format. See you then. Thank you.